operations office, demonstration VA. We have Jim Braniak, Georgetown, and on the telephone is Steve Scullin, California, San Diego. Why don't we start with Wes and just go down the table. You just, if you don't mind, with the ladies last. Can you stay on?
I actually am going to have to Skype in to give a talk in Seoul, South Korea, so it'd be better if I were to laugh.
Well, let's just go ahead first then. Got that scheduled. We do ladies first.
All right, thank you very much. Thank you so much, Dr. Shine and the committee. Thank you for heeding our input and that of the veterans. On an administrative minor note, I'll comment that my name is misspelled on the agenda. It's Jolond. I hope that might be corrected for the record, and I'll add that I'm also an RAC member, which I note was annotated for the veteran number. Regarding my bona fides in this area, I've served the nation with a couple of decades experience in primary care service caring for veterans, including Gulf War veterans. I was the sole civilian to accompany a high-level DoD mission to the Middle East on a fact-finding, fact-disseminating mission related to Gulf War illness in 1997. I was sole author or co-author on 4 of a series of 8 RAND reports on the relation of exposures to illness in Gulf War veterans. I've been a member of the Research Advisory Committee since its inception and served as its first scientific director. I've published on Gulf War illness, including a mention in TNAS, and this is an IOM committee. And by the way, that paper has some available data on gene-environment interactions related to Gulf War illness, and have current and past CDMRP funding for several Gulf War illness-related projects. I want to reinforce the comment made by Dr. White that the research case definition for Gulf War illness must refer to 1990 to 1991 Gulf War participation. Otherwise, similar symptoms, of course, can arise from a range of different causes. And for this reason, the definition must be not just symptom-based. For example, chronic multi-system illness can arise from hypothyroidism or from vitamin D deficiency. And while it is true that chronic multi-symptom illness in both conditions might benefit modestly from things like cognitive and behavioral therapy, lumping those conditions together or lumping conditions arising in different settings together may preclude identification of critical mechanisms and consequently identification of what in those cases have been definitive treatments and conceivably in this case definitive treatments as well. I would like to comment that because distinction of the 1990 to 1991 Gulf War exposure scenario is so important, because their exposure situation was different from subsequent deployment, to facilitate future VA research incorporating this criterion, I would urge the IOM committee to consider recommending to the VA that coding of veterans by the VA provide for separate coding for veterans of the 1990 to 1991 Gulf War. Right now, the Gulf War veteran designation by the VA encompasses any veteran deployed to that region during or any time after the Gulf War. This, of course, dilutes the group that we're most interested in, with many who did not show their exposures, and it is inimical to the use of this otherwise potentially valuable VA database for meaningful research on Gulf War illness. The case definition for different purposes must be given leeway to differ. This relates to and expands on a point made previously. First, and most importantly, the case definition for research and for critical care has different purposes and must not be confused. For initial research to understand a condition, the priority is maximizing understanding of the condition to best help veterans in the future. High specificity is vital in order not to dilute two cases or include in excess complex conditions that may add variance and extinguish significance to and potentially important findings. For this reason, the most classical cases should be preferred for first delineating mechanisms and identifying potentially valuable statements. For critical care, the priority is the patient in the present. And in this setting, high sensitivity is the priority. A decision to exclude those who may, for example, have a condition like multiple sclerosis may be appropriate or valuable for research, as the mechanisms associated with that condition Gulf War service. So to exclude people from a clinical definition of Gulf War illness that such concurrent diagnoses is inappropriate. For this reason, fewer exclusions of concurrent conditions should be in place and a broader net cast in order that those who serve their nation faithfully and are suffering as a result not be inappropriately denied the help that is their due. Case definitions for different research purposes must also be given leeway to differ in certain respects. There are some settings in which taking a subset of the broader Gulf War illness definition may be appropriate. For example, taking subsets defined by exposures, or as we just heard, lesions in which people serve, or symptoms, or identified mechanisms or objective markers. If there's a concern, for example, that pesticide or Haemophilus exposure may induce certain problems or involve certain pathways, then research involving Gulf War illness restricted to those with pesticide or Haemophilus exposure must be clearly accessible. Similarly, for investigations of diarrhea within those with Gulf War illness, restriction to those cases meeting most of the Gulf War illness criteria, but restricted to those with diarrhea is appropriate. And if there is treatment targeting a mechanism within those with Gulf War illness, then restriction to those who show evidence of a marker linked to that mechanism is also reasonable. There may also be instances in which it is desirable to take a superset, or a set that allows one or more exclusionary conditions to be present. For example, again, taking the case of MS, if it is an exclusionary condition for typical research Gulf War illness definition, studies that include patients who otherwise qualify with Gulf War illness but who also have the MS may for some purposes not only acceptable but important. Again, because Gulf War illness does not obviate risk of multiple sclerosis, but it may complicate multiple sclerosis assessment and may even potentiate its development. In other sets where a superset is studied, it should be stipulated that sensitivity analysis confined to those meeting the classical case definition has also been conducted. As the evidence advances, of course, the optimal case definition may be modified or, in fact, split if substitutions are identified, and leeway to allow research to follow the evidence needs to be included. My view is that a research definition for now should encompass absolutely Gulf War I, that is 1990 to 1991 Gulf War participation, with high specificity symptom criteria along the lines of those doctors feel, but modified to adjust to further accrual of symptoms with age and advancement of the condition. So probably requiring more symptoms and possibly splitting symptom domains differently, requiring more symptoms in an additional number of domains. It should also accommodate the accrual of health problems associated with natural aging, so relaxing or allowing some leeway for certain exclusionary criteria that are less likely to be subject to the case definition. I do applaud the notion of performing analytic work, such as that recommended by doctors to be able to determine what features best capture the excess symptomatology that is distinctive to the 1990 to 1991 Gulf War veterans in their more current manifestations. I urge the committee to include knowledgeable veterans like Anthony Hardy and others on a systematic basis throughout your deliberations. Keep the process true to the interests of the veterans whom all research in this domain should serve. I also urge that their input be taken seriously, and I second the recommendation made by nurse and veteran Nichols to incorporate one or more phases of larger veteran input, and perhaps also Gulf War researcher input before final determinations of the committee are made. The idea, and I think I'll actually end there to allow other people a chance to comment. Thank you so much for paying attention.
One quick question. I should have asked this earlier to Dr. Steele. I presume that you can use exclusionary conditions to characterize or define a syndrome, but still ultimately apply that condition, that diagnosis, that definition to a diabetic, even though diabetes has been excluded from Beatrice. Wes,
Thank you so much.
I know you've got it. Yeah. Beatrice, you've heard that. We want to be sure that you send a written version of your statement because of the difficulty hearing over the phone.
I'm sorry. I'll be pleased to do that.
Thank you. Wes?
My name is Wes Ashford. My claim to fame is that I spent 6 weeks as a medical student on the cardiac care unit with Dr. Shine as my attending in 1974.
And he survived.
And there I learned that the most toxic substance you can be exposed to is tobacco smoke. All is small stuff compared to that. As a psychiatrist, I'm used to dealing with illnesses based only on self-reported stuff. As a neuroscientist, I believe, as several others have already said today, there's likely to be some specific neuronal disorder that's underlying the symptoms that we see in these Gulf War veterans. I've studied Alzheimer's disease since 1978, and in 1997 I was asked to see some Gulf War veterans in my memory disorders clinic because of the memory difficulties that they were having, and I've seen them intermittently ever since. I've seen over 300 Gulf War veterans in my time. I've been the director of the World-Related Illness and Injury Study site at California since 2006. And these are the symptoms that everybody's already talked about today. This came from the Murphy paper, and the symptoms and systems are as they're stated there. And these are another one, the Iowa Persian Gulf group, that talks about the statistical significance of these things. This is basically what we reviewed when I was first seeing these patients, trying to understand what the problems were they had. So I'd like to present a case of a patient that was on February of 2011, a veteran who was in good health prior to his deployment to the Persian Gulf in 1990, flew into Saudi Arabia. He was deployed within a week to the Iraq border. He was with the 82nd Airborne in an engineer battalion. During Operation Desert Shield, he did mostly training, which he defined as blowing things up, preparation for the assault. The veteran developed diarrhea within 2 weeks, eating local food, fruits, water, vegetables. Vendors were selling food over there, but that only lasted 2 or 3 weeks. He was given medication for the Imodium, doesn't only antibiotics. He heard chemical weapon alarms go off at least twice, but on his mops 2 or 3 times. Saw a steadiness to fly overhead that never saw one explode. In Operation Desert Storm, he supported the infantry. He was blowing things up, disarming mines. He was at the weapons dump at Camisea, and he told me that he was the engineer that was responsible for the destruction of that facility between March 3rd and March 10th, 1991. So I know, where he was at that time. The reports were believed that he was exposed to all the things that have been listed: sand, smoke, oil well fires, insecticide. One of the things is he said he thought he was exposed to organophosphate nerve agents. If he was at Camisea, that was definitely in the area. What was remarkable is he did not die from them, which means that his exposure from the things at all was mild. TB tablets, and he came solvent, his anthrax vaccinations, certainly psychological, physiological stress. He was exposed to these guys. I've heard 124 different heat, and then they had to put on that mop suit. What that will do to your long-term brainstem mechanisms, I can only imagine. T4, TNT, and he was near large radar trucks. So he had all the standard exposures. Those were only other symptoms before he returned to the United States, though. But when he returned, he got he had to pay during fight. Interpersonal problems with his girlfriend. Had started developing diarrhea and constipation. Had some avoidance issues, problems. But the major symptoms subsequently were, as we've heard, chronic fatigue, muscle joint pain, different than fibromyalgia, I believe, more involved in joints and muscle pain, skin rashes for the first 2 years after return, but less so after that, sleep disturbances, GI disturbances, loss of concentration, forgetfulness, and memory loss. All things that were complained to me about in February 2011. Some of the symptoms were stable, the joint pain, but several symptoms got much worse. He had had 4 combat comrades who had similar problems, so these guys stay in touch with each other and they're aware of the other problems that they've got. This veteran also had parachuting, knocked unconscious for 3 times, not because you haven't seen it many times before, but to show you, let's see, I can show you guys can see I'm not to show the time that laser in anybody's eyes. He was with the 82nd Airborne, which basically went up here, and this is really just to show you where he went. They came flying right around here, right up to Delaware, it did, which is shown in the next slide, so that we basically know he would here at the embassy a bunker floating thing that time. But just showing you that, if you use these maps, before I use these maps, I had no idea what these guys meant. When I show them the maps, they'll show me exactly where they are. So these guys have many symptoms, but we do x-rays of their joints, they're normal, eye scans are pretty much normal, and the neuropsychological function usually turns out to be borderline, not showing very much. So it's really mostly symptomatic disease, not at this point about what is really going on. And just to tell you what our experience has been with the girls who speak the war-related illness study center in California since creation in 2007, we've had over 200 complex referrals. About 42% of them have been in the first Gulf War. The biggest single problem across all of them is pain. But when we break it down, I just for the purpose of this meeting, I broke down the pre-Gulf War I group, Gulf War I group, and the post-Gulf War I group. And the only thing that we see, and I'll just show you the actual numbers in the next slide, see they all have pain, but the Gulf War I group has more pain than the other. And this is just the actual numbers, and the preset numbers on the left are the actual numbers, the ones on the right are the percentages. And so I've broken this down into three things. Dr. Kilmer will show you some of his data, which I think is probably a little better. These are all based on PCRS records. Dr. Kilmer has the actual symptoms, I think, are a little, are similar, maybe a little more revealing. But the clinical patient record system that we use in the VA system, far and away the best one in the country. My wife works with Epic. Pain. The Gulf War I veterans have more pain than those before the first Gulf War or those after the first Gulf War. They also have more problems with chronic fatigue. They actually, although PTSD has been associated with, they have less PTSD, less traumatic brain injuries, less GI problems, believe it or not, and less dermatologic problems. And this is, basically 15 years afterward. Looking at sleep problems, cognitive problems, and pulmonary problems, you can think can be increased with age as opposed to related to the time. So the fundamental problem, I'm appreciating that this panel, not me, doesn't have to worry about trying to define this. Presumably there is an illness that exists. There have been many plausible theories, but none at this point is an acceptable explanation of this causation. There's no clear relationship to chronic fatigue syndrome, fibromyalgia, or multiple chemical sensitivity. One of the examples, I think, of a plausible theory is the concept that there could be idiopathic small fiber neuropathy, which is caused by many different things. But one of the questions, whether or not might be related to the anticholinesterase agents that veterans were exposed to. I think that that's been talked about a few times here. I think that the importance of that needs to be considered still. My attitude has always been that the pyridostigmine bromide TB tablets veterans took. Yeah, I've described this many times. Neurologists prescribe them widely to patients of myasthenia gravis. It's thought to be a relatively harmless substance, but let me contrast that with our Alzheimer's field, where we give cholinesterase agents that actually work in the brain frequently to our patients. Treatment is major FDA treatment for Alzheimer's are cholinesterase inhibitors, and the patients do relatively well on these drugs until you take them off the drug. And particularly, as well known with Aricept, most widely used drugs, you take the patients off of Aricept, and they have a precipitous decline, some much more than others. And I think that's something that hasn't been considered, that whether or not taking the pyridostigmine bromide tablet itself is not the problem, it was the withdrawal of those medications could have been a problem. And such a disruption, along with the insecticides they were exposed to, sarin is a questionable agent. But withdrawal of these agents may be related to, while you take these agents, there seems to be work done by Bonnie Davis, which I think is much representative, that there is a considerable increase in the amount of cholinesterase molecules that are produced in the body while you're taking the cholinesterase agent. And when you withdraw from those, of activity from nerve growth factor. And one of the things we know from trying to give nerve growth to Alzheimer's patients, it does create chronic fatigue. So I think that we should not give up on trying to look at this physiologic condition. I appreciate the committee's effort to try to come up with a chronic multi-symptom illness definition. It's very difficult. Soldiers go off many wards, come back with many different symptoms. That's one of the problems with this whole area. But I think that we still need to think about whether or not there is something unique. Maybe it's a constellation of problems that veterans are exposed to, where they're seeking a variety of insecticides. The course of being exposed to 124 degrees. There's a variety of things that could have come together to cause this particular syndrome that we see in veterans. And I think we should be trying to understand what the possible etiologies are. But certainly a large part of that is going to be to try to come up with some clear definition of a complex that you're working on. I certainly appreciate the work that you're doing, and I fully support it, doing what I can to help if they do need to catch a plane.
Thank you. Question, Mr. West. Have many of these patients gone on to develop full-fledged dementia?
Haven't seen it.
Just going to leave, so you have questions that's asked.
What's going to be, I mean, with, I know many of these people were young, but 50 years, so many thousands of them have been, going to be maybe out of the studies, people who have died, have had this condition, have been tried to provide pathological changes, things.
I'm not aware of any. I do think that one of the things that we should be doing is trying to go back to the National Death Registry and find out, the ones who have died, find out what is on the death certificates, because that would be available. That would be I think Dr. Seminara would have to do.
Howard, any questions?
I defer to Dr. Seminara. Thinking about the PV hypothesis that you put forward, doesn't PV not cross the blood-brain barrier?
That's true.
So you talked about it as a pain, but it could work peripherally nonetheless.
I will comment that I wrote a 385-page grand report on it, and I discussed this issue extensively in the chapter on dysregulation. There's a lot of evidence that exposure to acetylcholinesterase inhibitors leads to both persistent and also delayed alterations in regulation of the cholinergic system, many of which lead to downregulation, not all of which, but many of which lead to downregulation of acetylcholine disease, the number of quanta of acetylcholine per packet, density of acetylcholine receptors, sensitivity of receptors to acetylcholine binding, etc., so that while you remain on the drug, this downregulation is relatively masked, that when you withdraw the drug, this dysregulation is exposed. So in fact, there's a lot of evidence that was reviewed extensively in that report related to that issue.
Well, I think that
There's
Dr.
very good dose
Solomon
response data from multiple studies showing that people who receive more PD and PD longer, higher rates of sulfur illness and higher severity of sulfur illness.
Beatrice, I think he's asked, Dr. Teichman's asking you that question.
Oh, I couldn't hear. Hello? I couldn't hear it.
Do you see a threshold of effect?
I don't know that there are data adequate to show a threshold of effect. And this is one of the areas where there are some gene-environment interaction data. Senna Luckridge and others have shown that people with butyrylcholinesterase, which is an enzyme that breaks down PD, that have genetic mutations that relatively impair PD detoxification, have higher rates of, dramatically higher rates of illness associated with PD exposure. So it's an area, that defines where the threshold is going to be functionally different from individual to individual, because a given dose has a different meaning for a different individual depending on their assimilation and detoxification profile.
Hopefully, we're going to have your slides.
veteran panel. I've known Anthony at this point for over a year, and Captain Matt, I would gladly have served under him both for the stands up for his troops and also for the just the I'm going to fly through this. What I'm going to do today is tell you a little bit about my experience providing care for combat by comparing Gulf War I with OEF. I have a clinic in Seattle. I've probably done 12 and 15 registry camps myself, followed many of those people myself. We morphed what we call the Gulf War Veterans into a OEF, OIF deployment health clinic, and we've seen 7,000 Iraq and Afghanistan veterans in the clinic. So, I was invited here today as a clinician to take care of veterans, and not so much as a doc. But what I'm doing is in context of VA, so it's really kind of possible to separate that. But just to show you what we did was we had a packet of data that we collected on our Gulf War veterans and also on our OEF, OIF veterans. Essentially, clinic, this 700 Gulf War veterans, the quality improvement project, not necessarily published much of this data, but 700 Gulf War veterans, 152. These were the first 152 we saw in Iraq, just back in the war in 2003. Mean age a little bit older in the Gulf War because they had been back to long. Same thing we see today. Again, you look at the Gulf War group compared to the Iraq and Afghanistan, more symptoms across the board. Wesley and the British group has shown that symptoms across the board, almost every symptom you can see. Interesting, if you look at this, that I think back pain, which is the second one, sort of like, well, back pain is back pain, hurt your back, there's no difference. But most of these are symptoms that are somewhat more systemic and not focal. So we asked people about exposures across the board. For almost every exposure, there was more reported exposure and also not knowing whether they were exposed or not. And so this kind of uncertainty is also discussed. And many of them are heart pain, TB tablets, and so on, aren't on this list. They're all the same. So more reported exposures and so on. Attribution. If we ask for that personal for sleeping toxins, you're more likely to attribute them to exposures because they experienced more exposures and they were probably exposed more. So here is that the only ones that are that are more common in the Iraq and Afghanistan veterans, or the Gulf War veterans, are things such as my symptoms are likely to go away, my symptoms are caused by PTSD, and that's not the experience of the Gulf War veterans. And it's because they weren't. The prevalence to show that. Just more attributions here, and I would invite you to look at these slides on your own time. It's very interesting, giving us a little better idea of what it was like in Gulf War compared to Iraq and Afghanistan. If we look at combat exposures, more classical combat exposures, but fewer environmental exposures and threat by toxins. And I thought about this earlier today. In a sense, a simple alarm going off and having to get into mop here within 45 seconds or you might die. The training that people had before they went over was really like a mock execution. Many years I took care of many ex-POWs who had experienced mock execution and had it thinking die. This was no small thing. This was people experiencing something that was so terribly traumatic. When we look at other sorts of traumas, really like traumas, they're the same as those you would expect. So, less PTSD in the Gulf War group, and more what we call somatoform, more symptoms. The other thing that's important to look at is depression is kind of high in both groups. That's why, it's very important that we keep mental health on the table always, because there are all sorts of actually, Captain Burnett was saying that, it was important for him that he also got support for depression, but it's the metaphor simply means physical without an established psychiatric. So when we look at functioning across the board, the Iraq and Afghanistan veterans, we're doing better than both of them. So this group has a lot of symptoms, a lot of exposures, and not doing well, not functioning well. So again, look at the future. This is interesting when we look at subscales of psychological functioning. It was psychological impairment was greater in the Iraq and Afghanistan group than with the exception of physical symptoms. But otherwise, psychologically, we don't evidence
have physical symptoms, go to their doctor, doctor looks at test is negative, they send them to mental health thinking, well, maybe it's not depression, we don't know. Mental health would look at them, they had a bunch of symptoms, physical symptoms, didn't meet criteria for any diagnosis. They sent back, they're back to their physical doc. And the point of this slide is, and that is asking physical doc, medical doc, and mental health doc is both for illness or medical or physical, physical, that's for mental health. The point of this was our model was working. We thought, we asked what's the best treatment? Is it biologically based treatment, psychologically based treatment? The physical doc said probably psychological, mental health said probably some physical intervention. Smart doc, Walter Reed, D.H. Portland, the model was working. So our task was how do we take care of people coming back for veterans? This is all that's going on this way, how we're going to approach it, and our model was get our arms around this and support for them in all these different arenas which are helping with care, including when we think about CMI, the only going on any of part of this population. Model of care which is primary care, mental health, both work. This was there was some note of this in the last Iowa report in terms of models of care. This is kind of a big slide with a lot of stuff. But basically, the VA now is using medical, which is called patient-aligned care team. The idea is the veteran has care built around it, includes environmental clinicians, registry programs, the GOFA registry program, the post-deployment integrated care channel, and so on. So that's kind of the way we've approached this care of these veterans from both works. So I just quickly am going to go through in terms of talking with veterans about what we know and what we don't know. It's really important that we're clear about what we know. What we don't know is we don't know the specific effects of exposures. We don't know the causes of these symptoms we're having. We don't know the relative contributions of the different exposures. We don't know the long term. We don't know the effects. So we're monitoring those. That's something we need to tell veterans. But who we know the symptoms. They have certain constellations of cognitive and so on. We know that they're more exposures. We know that they're general. Lots of stuff. So what do we do? As providers, we know that this is something that we encounter in other settings. Don't positive care of people. So again, our clinical approach has been how we support people in regaining their health after they've been through living with medically unassisted. It can be more challenging than living with a diagnosed condition. Any context know that it's difficult. So to say that we don't know isn't to say that it's not to say it's psychological, it's not to say it's not real, it's not to say it's not physical, it's not to say it's not a serious symptom, and it's not to say that it's lots of symptoms. To say that we don't know is to say complicated, can't live without it, and bullet, time, effort, and so on. So this is sort of a model of care that we've come up with after this. So start out with service, change service, validation, and so on, and include research on clinicians and questions. We need to look for other specific etiologies to try to explain pathophysiology. So we also need to support them, which one of the nice things that happens today are some service connection people that were just having symptoms. Don't have to have it very proactive. Like the Agent Orange program today is also proactive. So then to finish, we're trained in medical school to look at red circles of people's experience, yellow circle, and the red circle are diseases, yellow circle is first experience of being killed. Killing is symptomatic disease, like the person has strep throat, asymptomatic disease, it doesn't overlap with them. High blood pressure, elevated blood sugar, but if wrong, we're not both for veterans, is an illness, kind of pathophysiology maybe here, maybe we're partially explaining what's going on. Pathophysiology, I would get sort of this point to understand the subgroups, maybe to understand the pathophysiology. Maybe at some point we'll understand the pathophysiology. But at this point, take care of the big red circle. That's what we're doing. We're trying to take care of that, regardless of whether it be base definition we looked at.
into account. Certainly, the environmental exposures were unquantifiable exposures. And the other is we're trying to be able to better standard of care. So if there's any way to work for the idea to mind that the wrong method is a new territory in ways that centers we have to come up with that. I think people struggle with making it small enough to work, big enough not to. This is very, very important. Big definition, you don't want it to. And that we use nomenclature and language that kind of leverages the use of a case definition without getting away from the centrality of the so know the way the war affects people, know that it's complicated, I kick that like
Steve, thank you. A couple of quick questions. One, what kind of outcomes do you measure from your group activity, and what effect does it have on the natural history of the disorder? A lot of the data that we've seen is this is certainly chronic, not progressive. Can you interrupt that progression?
No, the epidemiological studies show that it's like chronic fatigue or fibromyalgia, up and down. It doesn't seem to go away. There's like there was a large multi-site trial, and we actually had the largest trial so that exercise was helpful. So I think there are things that we know about. Our randomized trials that people that long.
Questions? Steve's also sure. Thank you. Drew, what's your name?
Hi, my name is Drew Helmer, and I'm the director of the War-Related Illness Studies Center in New Jersey. Thank you for the opportunity to share my perspective with you. It's really quite an honor to be part of this today. I'm going to just quickly flesh out a little bit of what you said with regard to employment health. War-related illness is part of VA employment health care, and we took it very seriously and try to provide a holistic vision for the patient and the healthcare veterans who were deployed to combat. So the slide Steve said the veteran really at the center of care. The VA is evolving its care approach to deployment health, and all of form what I have to say about the goal for veterans that initiative war-related at risk war-related illness. But I think just to reiterate that surveillance at the most basic level, primary care is really the entry to the VA. Then there's local efforts, so there's developing the environmental health program, and then the war-related study serves as a tertiary care role evaluation point where veterans who have difficulty diagnosed referred by the VA provider come and see us or interact with clinical services. This program was actually funded by congressional mandate in 2001, and it kind of grew out of the first goal for veterans, why we're here today. And as I mentioned, well, the RIC actually helps deploy veterans of any era, and we do focus on those unexplained or unusual health conditions. We do this through clinical care, education, and I just want to emphasize that although today I'm going to focus on clinical activity.
Yeah, I can close the door, Carol. I was fine until you came upstairs.
Might help you understand a little bit the West California right up Orange, by the country are and our main clinical services are comprehensive disciplinary evaluation, on-site evaluation in 3 to 5 days. It's multiple providers seeing the patient over the days. We're focused really on symptom management, consult, refer to the patient as the most appropriate give a little more detail about the comprehensive evaluation.
Did that hurt?
The criteria for having a comprehensive evaluation are fairly simple in concept, but they're subjectively determined. I spent some time talking about this because when a patient is referred, our team sits down together and reviews the referral written by the provider, reviews the medical record, and reviews what we call the intake packet. Self-reported response by the veteran, quite lengthy with the questions and standardized instruments, discussing symptoms and other aspects of their health and medical history. We use this to determine, what the best level of service for the patient. When we see the patient, we take a very holistic biopsychosocial approach. As I mentioned, we have an interdisciplinary team that actually works with the patient. And the evaluation culminates in a team patient speak where the goals of the patient are articulated and steps are actually negotiated, written down, and the emphasis on optimizing health function, emphasizing self-management, and goal and outcome oriented. To round this off, we encourage timely reassessment of patient-month care and we try to ensure a smooth handoff that referring team and we follow up once. So how does chronic multi-symptom illness fit into this picture of what we do at the rate? So the first time this becomes part of the process when the provider or provider is asking, what is medicine? Why do you want the risk to see your patient? So that's the first time we actually deal with the concept of chronic multi-symptom illness, that review of the referral. As I mentioned, in order to optimize our services, we review the materials that are available to us, and we explicitly ask ourselves on this issue, well, what's medically unexplained about this patient? Does this patient have what we might consider chronic multi-symptom illness? We don't have a definition that would be very handy if we did, but it's really a very subjective decision based on symptoms, number of birth, about whether a patient has been to their exposure concerns that they reported on packet, and also the workup that's been done up to that point that's documented in the medical record. Second time that chronic multi-symptom illness comes up in the evaluation and what the risk of clinically is really a team sits down together before they put the patient and say, well, what have we all found? And the team doesn't usually use the term chronic multi-symptom illness. It basically talks about patients, acknowledges the complexity, the chronicity, the multi-symptom aspect of what's going on, the interrelatedness of the health problems from this biopsychosocial approach. We have our social worker there, we have our RN educator there, our nurse practitioner, our med doc, and it comes together and share as a psychologist, and they come together and they share their perspectives on the patient and how these interact, how these different things may interact and impede something and contribute to reduced health. Finally, I think the other way that we talk or think about chronic multi-symptom illness at the risk is really our lack of using it as a label. We do not ever tell the patient you have chronic multi-symptom illness. When the IOM report came out in January, it said chronic symptom illness, kind of looked at it, oh, that's interesting. And there's something we can pull from that to actually apply to our patients. And we decided no, that we weren't ready to change how we talk to patients about their illness. In contrast, however, we actually do use the case definition of chronic fatigue syndrome, fibromyalgia, irritable bowel syndrome. So we're pretty explicit about how we use those terms throughout a 2001, 2004. And we heard directly from patients that
Look at your screen.
And we ended up fibromyalgia as a way of documenting presence of condition, so that it was clear in our notes that we actually did an actual documentation about chronic syndrome, fibromyalgia. We're not doing that chronic. I did want to share a little bit of more objective data from our clinical experience. So this is similar to what you presented. So the symptoms of the patient health questionnaire, and this is asked as part of the intake packet. The number is probably a little small. The main point here is that there is greater than 40 veterans for the first bus, New Jersey, and the Gulf War veterans did have higher rates of reporting back pain in the arm, like joint headache, gastrointestinal symptoms, constipation, followed by diarrhea, nausea, gas, just feeling tired or abdominal. So this is a similar pattern to what's reported in literature of notioma. The same symptom reporting for more recent combat veterans. We also did a little preliminary analysis looking at health patients from both for veterans and the relevant pay, but the use of patient actually went up. And these are the SG9 codes that were documented corrected at 1 year after. And so you can see how the number of documented SG9 codes went up pretty much across the board, but then ones that had the highest number of reporting for mental illness, the undefined, really differentiated signs of condition, and then the muscle health symptoms. So in summary, I just wanted to share a little bit of our chronic illness risk perspective, and reiterate that chronic multi-symptom illness by certain concepts of the risk that we don't use as a label, and our clinical experience does demonstrate a pattern as documented in other cohorts and other studies. And this is a clinical population, this is for the care population. And finally, I was thinking about your task and the utility of the condition. I would welcome a better, more defined, generally accepted that having a label to help us talk to patients, provide a little more certainty, and generate perhaps a more optimistic future for better.
Thank you very much. Two quick questions for you and Steve. What proportion of your Gulf War veterans are employed versus not employed? Are they working? And secondly, if you were going to use a name for this, whatever that definition is, what would you prefer to be able to tell a veteran, given all the different terms that have been used? Your clinicians, talking to patients, what would make the most sense to you in terms of saying to patients, I think you have.
I give you the ballpark would be less than half of our local veterans are employed outside of the house. And that's partly a function of as a tertiary care referral center, we'll have to travel and people are we have less.
I would be interested in that.
Personally, I guess I like to think of health and function, and if I had to pick a label, I would probably go I